It is a huge honor for me to be podcast interviewing a legend in cosmetic dentistry, Dr. Martha Cortés. How are you doing, Martha?
I'm doing wonderfully, really great.
Thank you so much for doing this podcast with me. I love what you're doing. Let me read your bio to my homies. Dr. Martha Cortés is a committed and knowledge-driven dentist who has been in practice for over 30 years. Her practice is located in New York City with a focus on general, cosmetic, and biological dentistry, with a subspecialization in TMD, TMJ dysfunction, and sleep apnea. Dr. Cortés is a graduate from the State University of New York at Buffalo and completed her general practice residency at Mount Sinai Medical Center. She has been teaching since 1990, initially on the topics of cosmetic dentistry, periodontal laser surgery, followed by holistic dentistry. Currently, she teaches the non-surgical treatment of TMJ dysfunction and facial enhancement as the first certified instructor for Bio-Modeling solutions. Dr. Cortés has served as the international chair of the American Academy of Cosmetic Dentistry, the president of the New York Academy of Cosmetic Dentistry, and the co-chair of dentistry at the American Society of Laser Medicine and Surgery. She also holds an academic position as an assistant professor in the Department of Orthopedic Surgery at the New York College of Podiatric Medicine, associated with the Foot Center at Cornell Medical Center. Dr. Cortés is a diplomat of the American Board of Craniofacial Dental Sleep Medicine, American Board of Craniofacial Pain, and American Board of Aesthetic Dentistry. She has a master's from the International College of Craniomandibular Orthopedics and is a fellow of the Las Vegas Institute for Advanced Dentistry and the International Association of Dental Facial Aesthetics. It's exhausting just to read everything you've done.
You know, when I usually lecture, I go, I think they forgot ADD, ADHD, because man, I think we have an extra little bit of alphabets that should be there. ADD.
It sounds like you've been in search of excellence your entire life.
I love to study. And the other thing is, I hate to tell you, I love the shiny metals. That goes with the diplomates.
Oh,
and
yeah?
So, yeah, I did a master's in biochemistry, and some of the studies, we studied all kinds of genetics. We studied the different animals, different species, biochemically. Okay, and one of them was about the gorillas loving shiny metals. So I decided from day down, I'm a gorilla. I love shiny metals.
Well, you are the 400-pound gorilla in cosmetic dentistry. You've been at the what has it got you most excited now? Is it the cosmetic facelift through craniofacial osseous remodeling?
Exactly, because the whole thing about like Las Vegas Institute was brilliant experience. Now I still use the full mouth reconstruction when it's needed, when it's a TM. So I would solve it with a lower orthotic, a TMD issue. Work with the neck to get in the right position, work with the posture, and you'll see some slides that I'm going to show. And then from there, I would do a full mouth reconstruction, because then you're doing a full face makeover in addition to the smile. That's one part of it. So I can do TMJ sleep that way. The other part of it is, why does it have to be in porcelain? Why can't we do it naturally? So then you use orthotics. You use orthotics for TMD, but then you use an actual appliance that expands the jaws, brings the lower jaw down and forward, brings the neck up, and actually expands the upper jaw, which who would ever thought that we could actually expand as an adult, not just a child, the upper jaw. And that's the difference, and that has me really excited to teach it, because while you're doing that, you're reversing the sleep apnea. You're developing the 3D anatomy.
You're amazing.
No, it's just fun. It's just wonderful, and it's wonderful to teach it and to see that glow in the eye when somebody gets it, like, oh my God, like, but it changes you, because now you don't know if you're going to be satisfied with just bringing, for sleep apnea, the jaw down and forward and creating an airway. Now, do you really want to do that, or should you talk to your patients about developing the rest of the anatomy around it?
Nice. So you're going to show a presentation now?
Part of it, yes. It's a lot of slides, but it's actually a quick slide. So let's go to it. Okay, so if you look at the screen, actually, you can see that I did this black and white silhouettes because you can actually see how the jaw changed here from almost a class 2 to actually a prognathic jaw. Notice how the neck changed. This is common on all the cases that we do. Now, how I first used to do it is look at the neck. Look at this neck, how the neck actually gets longer. Look at the smile, how it gets broader. And then look at the zygomatics, the cheeks actually lifting as the eyes also lift. So this is in full mouth reconstruction, but this is a lot of porcelain when someone really needs it. When someone has really utilized. Now, what age do you think this person is? What do you think, Howard?
60?
20 something?
Wow.
Yeah. So at this point, he had worn so much of his teeth. At this point, all he wanted to do was simply marry him off. He was too young not to be dating. He was a young professional, but look at this face. This is where he got engaged. And I told him he was like an Adonis. It turns out his father was the Adonis and his mother was the Miss World. But somehow he ended up with these kind of teeth worn down in acidosis. That's what it is. But look at this neck. Look at the beauty of the neck. So I wanted to do that more biomimetically. This is a serious TMD case. In such pain, had the actual left arm had numbness. Forget about tingling. Numbness, disuse 50%. The left leg disuse 25%. Dystonia, dysphonia, and Parkinson-like symptoms of moving up and down. So again, you see those little baby blues in her mouth? At a vertical dimension of like 23 with those little bite taps, we were able to find a position where her neck was longer, and she stopped doing the Parkinson bob. The dystonia improved, and this is with the full mouth reconstruction from the TMD issue and taller. Do you see how lovely she looks?
Very much so.
She looks 70. She's 70 without a facelift.
Very nice.
Yeah. So here we have a 20-year-old, 20-something-year-old. Here, she actually has an MRI that says she has a disc issue. From here to here, it was 6 months we did TMD, disc recapturing, and here we did remodeling. The real change, you see how her actual nose improved, but it's not really the nose, is the zygomatics developed. The side is when you really know the difference. Her jaw, her neck, and her jaw repositioned itself. So you bring the lower jaw down and forward, and the upper jaw gets developed. Usually their lips get a little thicker. Their nose becomes lifted. You can believe this?
Very nice.
Now you see how she's a mouth breather. Often a lot of these people are mouth breathers. So this is a TMD with an upper airway resistance syndrome. All of them have very similar things where the rotation of the head, where are we? Going back. The shoulders are not leveled. There's clockwise rotation of the head. We missed a photo here. Okay, so let me go back. They have clockwise rotation. So if you look at the head, it actually twists that way. If you look at the neck, it falls back. So she has a C1 problem. Look at the shoulders are uneven and the arms are positioned forwards. And this is overpronounced. This is typical of all these patients. So they have the forward head posture and the lumbar overflexed. How I look at these cases, I look at facial diagnostic. Where are the eyebrows? Where are the eyes? Where are the ears? And the side view, again, where are the eyes relative to the mid nose? Because this tells me the pace of their cranial base. Is it short cranial base or is it long? Because the short cranial base will always have a tendency to have a problem of an underdevelopment of the upper jaw. Why? Airway. So then I keep looking at the eyes. I look at the vertebra. You have to have enough space. This upper vertebra, the first vertebra off the occiput, the cranial part of the cranial skull, has to have at least 9 to 11 millimeters. If they don't, they have excruciating pain. This mandible, this plane, cannot be very steep. Other way, again, they've had sleeping disorders. They all have the forward head posture, but then they have a lot of head and neck. Now here you would also look at their tongue tied, because part of this relief that I could utilize is to actually release their tongue tied, because often this head forward posture involves a tongue tied. Our society has become an issue of the webbing of the tongue it just doesn't enzyme reduce the webbing in their tongue tie. There's a higher incidence of tongue tie, higher issues of breastfeeding. So what else do they have in common? They always have a cant that's off, the eyes that's off, the one ear is lower than the other one. Because they don't have enough room in their mouth, they often the tongue is laterally folded in. They often have wearing of the tooth structure. And since a lot of them actually grind, and you have to ask the question, what is grinding? Grinding can be a movement disorder because they may not be an apneic. Look at this. Look how ground down they are. It's very ground down for such a young person. They can be an apneic, but they may not be a full apneic, so they start breathing 5 seconds versus 10 seconds, which is the index point. So I look at all these things. Often vertically, they're compromised, and they're from their first molar to third molar should be at least 38 millimeters. She's 28, so she's essentially 10 millimeters deficient on the upper jaw. A lot of them have issues with the condyle, so that they have grinding and parafunction. So that this is what she actually developed into. Not bad, huh?
Beautiful case.
Yeah.
I noticed she also had 4 bicuspid extraction
I
orthodontics.
was waiting for that. I left you open for that. Yes, unfortunately, not all orthodontists do this, but here you can see it where the lower bicuspids are missing. Now there's 2 ways of doing orthodontics where you can remove the bicuspids or sometimes the wisdom teeth and bring forward the upper jaw and the lower jaw. But some still actually then do retractive orthodontics. The teeth look great, but unfortunately we're retracting back into the airway space. So this is the orthotic that I usually use as a lower TMD. It's actually indexed in order to move the jaw down and forward, which now allows the jaw to come down and forward and then the neck to be released and longer. So she got 2 centimeters longer. These orthotics are worn 24/7 hours, essentially 22 hours a day for 3 months, which actually lengthens the condyle a little bit and allows an increase in vertical, by the way. It's an interesting, simple device. You cannot wear it more than 3 months straight because then you're going to do too many permanent changes. You're going to marry them to having to do super eruptive orthodontics or having to do an arch. So 3 months is good. Now this is called a DNA. It could be a DNA, it could be an ALF, it could be a Prozac. You just need something to actually open up the arches. So it's called biomimetic. We're going to go through this quickly. It increases the nasal space, the posterior and the anterior nasal space. But I'm actually going, okay, good. I actually want to show it, I want to show it physically. This is the beginning. And this is what she expanded to.
Wow.
So yeah. And this is an adult.
So it flared out the angle of the teeth?
It's really amazing because what happens, you saw the face. So you're actually increasing the alveolar bone and the teeth are not being pushed, the whole body movement of the root, but also the bone actually increases. It's hard to show this here.
No, I can see perfectly.
Yeah. And this is a simple case. This is not extraordinary. So you can end up having very wide bite.
Wow.
And we know that now, what's interesting, you always have to ask them, do you want to develop the space where the bicuspids got taken out? I said, that's going to be another 10,000 easily because it's going to be your implants and post and crown, or we can literally slide the teeth forward without braces. These are not braces. Remember, these orthotics are only at night. So they're wearing it 12 hours at night, sometimes 9 to 12 hours, but you're developing both upper and lower. Another quick, I have to show you this quick one.
Oh, okay. No, take your time. You got all day. This is
really?
Friday. Yeah. Take your time.
Oh, I like that. Okay. So That's the one I just showed. So what happens, they actually increase their vertical. But it's more dramatic is in the face because you're only, when you physically measure it out, it's only 4 or 5 millimeters. But what happens is the whole width opens. It's the whole thing.
Right.
And it's bone. What's also interesting is that attached gingiva actually gets thicker. This is something nobody talks about with these. The gingiva, because for the pinhole surgery, I took a few cases and they said, your patients will have 5 to 8 millimeters of attached gingiva. How did you do that? I said, oh yeah, I osseously remodeled them. So there's an interesting little detail there. Okay, we're going to, good?
Good, very good.
Okay, going to another case. So this one, again, another 20-year-old. This is her real open bite. So this is not eating, no salads, no food, a lot of plaque because she's not eating. So again, she was TMD. We did the MRI for the disc that's not recaptured. So a lot of them have anterior disc displacement. In pain, this was her open bite. When you see an open bite, you have to think airway. You must think sleep and airway. It's the airway that's required for the survival mechanism. This is closing it. Now, this was, again, expansion in the back with the DNA. And I could use an ELF. I'm not married just to the DNA. I can use a Prozac. But it's a removable appliance. And from there, for her, because she's an actress and we were commuting from London and New York. So for that, then I closed it with the Invisalign. So this is, look at this closure. Believe this. I don't believe it myself, by the way. I do these cases and I'm like, that is amazing. And here we did one more envelope because she's still just a tiny off here. Here she's closed, but that's how she was originally, totally open.
That is simply amazing.
Now in her body, she's gone from pain, extreme pain, forward head posture, to an improved posture and an improved facial aspect. From 13 to 15. Now look at the smile on her face. Her smile tells you, I am not in pain. I can eat. I am an actress getting gigs now. Yes, I hurt my knee and my ankle. But do you see the improvement in the posture?
Absolutely.
Yeah. Okay. This one's face only. Okay, so again, she was interesting because every afternoon she was napping. So in the facial diagnostics, too much of her white is showing, too much and a little bit of venous pulling. So that means her underdevelopment of the maxilla. Even though she looks good, she can't really breathe through her sinus area. She did see Dr. Stephen Park, who referred her to us in order to expand her. He decided that an expansion would be more appropriate than to actually do surgery. This is a year later. So now she's being able to not to have to take a nap of 2 hours every afternoon, being more productive, working. But I want to show you the x-ray. Look at the x-ray here. This is the before. You see where her upper vertebra was up onto her occiput? That is pain. She was in a lot of pain and then had a nap every afternoon. This is her new one. She has the normal, all this open, by bringing her jaw down and forward. So we brought her jaw out of the way so that her head can go back and her neck can reposition itself. And these are natural shots. They're not, they're just take a breath and let it out. Okay, here comes the ICAT. You can almost see, though, a little more opening here.
What are the sensors on the back of her cranium?
Those are hairpins. These are
hairpins.
We women put extra little pieces of hair and we need something to hold it. So she probably had a little ponytail attached to that.
Nice.
Yeah, you would not know that.
Being a bald man, I did not know. I figured it was some type of a sensor.
So here she actually opened up the area. It's a big area difference.
Huge.
Yeah. Here is trying to show that a lot of them also literally turn their head. It's so interesting because they have this torsion in this whole body. All these people with this upper airway resistance syndrome, TMD, so that they torsion here. You can see how this, they torsion, it goes up, and all of it steadies. These mandibular angles are pulled because of head and neck pain. The muscles are spasming and deforming them. You can see the distortion. Here's flatter, this is more angled. This was much more angled before. And the condyles were brought down and forward away from the retrodiscal tissue so that there's diminished pain and eventually no pain. And this is what's really good. Her airway went from 15,000 to 33,000.
Wow, you doubled her airway.
Because you're doing remodeling and you're opening it up. And she got out of pain, which is more important. Do you have any questions?
No, I'm loving this.
Okay, so all this underdevelopment is really about jaws causing. Now, every patient's not going to show up the same thing. Some of them will be malocclusion, some will be TMD, bruxism. Bruxism's a big deal because our society is convinced that there's only 24% of grinding, bruxing during the day and only 8% at night. Okay, why is the 8% in my office all the time? I don't think so. I think it's higher. And bruxism, remember, it's a movement disorder. They have to have sleep apnea. They often have headaches and migraines. You're cutting down their longevity when they have all these facial compromises. We have to look at craniofacial features as if it was periodontal disease. What is snoring to sleep apnea? We cannot just look at craniofacial and say, oh, that's their gene. They're just a little smaller. No, it's their airway. So we need to learn how to assess all of us, not just people who are specialized in TMJ and sleep. Children show up chapped nose, chapped lips, gingivitis are really telling people I have low oxygen. My brain is not going to develop really well. I'm probably going to have some cardiac hypertension. Look at and this is also behavior. This kind of face comes, and look, see how dark under the eye and white under the eye? They're going to show up behavioral issues. So some of the ADHD we're addressing by developing their jaws. There's even antisocial, especially the boys. I'm sorry, the boys just seem to get worse than the girls. And there is a study where the estrogen actually prevents the young girls from getting a worse spectrum issue like the boys. The boys the testosterone doesn't help them. They just have more issues, and supposedly it's going to get worse as we are a society of more toxins. It's the allergies, it's the pathogens inside the allergic. The bruxism of children is really issues with their ears. It's airway. All that airway makes their tongue have a lower posture and therefore an underdevelopment of their jaws. This tongue, see how the tongue is here? Here's the tongue. This tongue's supposed to be up here. Matter of fact, an exercise we can learn right now. Remember when you were a kid and you would make believe you were on a horse and you pull up and you see how your tongue is from the back? That is the way how to teach this tongue to lift up. And this tongue to lift up here because it belongs up holding the palate, being anti-gravity. Now the other myofunctional, I'm a myofunctional therapist also. The other one is to go cluck, cluck, and then the other one's the cave. But you have to form a cave. Do you see the cave?
Yes.
Mm-hmm. And then the horse. And then I tell people you must get a gum called Falim, F-A-L-I-M, and you chew gum twice a day, 20 minutes. So I've developed this better. I'm 62, hey. And then this is all muscle to lift the face. So chewing gum twice a day, 20 minutes, plus it opens up the airway because airway is soft tissue and muscle. And if your genes are sleep apneic, man, it's going to be flaccid. Besides being vulnerable to Parkinson's, Alzheimer's, sleep apnea. This little kid, look at her, mouth breather. They're not going to develop their brain. And now the latest studies out of University of Pennsylvania, talks about in the rabbits, the first tissue that doesn't get oxygen is the frontal cortex, as in frontal cortex, anterior cingulum, judgment, executive disorders. They can't integrate with the back of their head, so they're going to have sensory integration issues. The rabbits are showing that now they're looking for kids. So when we see a kid like this, we're going to think about the brain is not developing as well. It's not just the mouth not breathing. It's not just the nose. See how small the little nostrils? They're not being used. Anyway, that causes a venous pulling under the eyes. And what happens is the blood's supposed to drain backwards. It doesn't. It drains through the facial vein. And that is all because the maxilla never developed. Why? Because the development of the anatomy is due to the breathing apparatus. And we end up with these little kids with little spaces. So that little kid's going to go, I don't want to do anything except drink my bottle. I don't want that. I don't want to eat that apple. I don't want to eat that piece of bread. Why? Because they choke. They don't know how to tell parents, I'm choking. I can't eat that. I will only. This is very compromised behind the base of the tongue and the uvula. And look, it's an open mouth breather. So our society is having a lot of trouble. This is one of my little girls. She's a sleep apneic. She already had adenoids removed. She already had her tonsils removed. She is posterior crossbite. You see a posterior crossbite? There's no such thing as unilateral. It's both. You see the open space. So, okay, so she used to suck her thumb, but that's not really it. They have two theories. Some of the kids that suck their thumb is actually stimulating their pituitary. There's something missing that they have to percussion their pituitary. So anyway, when I saw her, she was transferred from a pediatric dentist that she was with. She was transferred to me at 6 years old. I sent her for a sleep study. I said, you may have had your adenoids removed and your tonsils. There is a problem. And she was very hyper. I literally had to run. See how the pictures? I had to run around the office to take pictures of her when she first came in. So we expanded. You see how wonderful? Look at this. This expansion. You could do it very fast, but this is removable, so you're really moving the whole bone. You're not ripping the suture, the transpalatine suture, and you're allowing the teeth to come in. And in her case, we're doing myofunctional therapy. The study shows that she was a sleep apneic, and then the study showed at this point that she's no longer sleep apneic, but she still has the habit of the tongue, despite all the myofunctional therapy. So, guess what I did? I put little braces on her. So here, I put little braces, including all her deciduous teeth, and I did a reverse 014, nothing else, with a little bit of Damon on her teeth very, very gently. 014, which is just a leveler, and we were able to close her bite. So she no longer has an anterior bite. Her tongue is not there, and we've reversed sleep apnea. And she is a year, actually a little longer than that now, from reversing sleep apnea. And her mother said, what am I going to do, put a CPAP on her? Are you kidding me? Because that was the other choice, was to put a CPAP or go through the myofunctional therapy and all the work the kid had to go through us. What do you think about that?
What an amazing, life-changing treatment.
It is. Because you see these kids going from real hyper and running around, and they can't study. So what happens, you see these little kids become like little namaste. They start doing their French homework. They start doing drawings for us, and all because we got them an airway space. Despite, now remember, adenoids and tonsils, 50% of the surgery has residual sleep apnea. They have residual sleeping disorder. So adenoids alone is not enough. You see any of those tonsil goobers in the back of their throat, they must be seen by an ENT. And I'm very holistic. So for me to say surgery is a big deal. There are other methods, but you have to create the airway. If you don't create the airway, this is what you get. You start getting V's instead of having these beautiful Gothic. Now, prior to the industrial age, we had 50 millimeters across here, from here to here. We're down to about 40, maybe. Most of the patients now are 30. And what's bad about it, takes up the nasal space. You see the nasal space is being taken up when you have a higher palate. So you lose this whole nasal space. So now they become often mouth breathers. Oh, maybe they're only seasonal mouth breathers. They're 30% cannot breathe all year, 30% are seasonal, and then there's another 30% that are in and out because different allergies. Look at these. These are huge. They have to. They're kissing the uvula. They're large. So they're preventing the development of the whole maxilla. So that here we have that it increases the resistance of the nasal airway. Now, you know what's important about the nasal airway?
What's that?
The cilia and the nasal airway. They have cuboidal cells, and then you have the little cilia sticking out. When the air flows to the cilia and makes them flow, there's nitric oxide that's released. So you actually get a bigger nasal space. But you know what happens to nitric oxide also? It goes to the lungs. And so therefore you're reducing the nitric oxide that would open up the lungs for better breathing. So it's not a simple thing. This is a very serious thing.
I notice all the professional athletes are obsessed with breathing through their nose because they get better performance on the field.
Exactly. So as a, what's it called, PPMs, a performance orthotic that I did for several athletes, because all we did was essentially close to a neuromuscular position, which is a physiological position. We brought their jaw down and forward slightly and opened up their vertical. Their performance increases by 30%. And this is using the same thought behind the expansion, but also the positioning of the jaw and that neck, lifting it up. They get taller. Kids, oh, I didn't show you the pic. The kids pop, not 2 inches. I don't know if I put the other case in. I don't know. I don't think so, maybe. But there's one kid that popped from 10 years old to 12 years old. She went from really I'm small, I'm 5. She was smaller than me. That's a big deal. She popped to almost a 5'10". She's 12. And, I'll show you. I think I have that case at the end. So anyway, some of the next slides you're going to see are from Dr. Singh from Biomodeling, Dr. Brian Palmer, chest physician Joy Moeller, and Alan Moses. So the question is, what is epigenetics? Orthodontics. Essentially, you're looking at the skull and all the cranial bones as one piece. You're looking at that it's all connected. So when you start, this maxilla is connected to the ethmoids, connected to the frontal, connected to the zygomatics. The maxilla has a transpalatal suture, and that's what we actually stretch the sutures. And when you stretch the sutures, you actually are stretching this space. It is a craniofacial suture, which means it has a suture homeostasis of 250 microns. And when you stretch it, the fibers actually stretch the bone and actually cause woven bone to be deposited. When it goes to 400 microns, it actually deposits bone. And that's why you can actually stretch this. And that's why you're getting all these actual craniofacial. And it's not just the maxilla, the temporal plate. When you bring the jaw down and forward and you expand into this area, there are 3 sutures in there. It actually stretches those sutures open. So I no longer just bring the jaw down and forward, I open up the glenoid fossa. So that disc has a better position and expand the rest of the cranial bones. Because it's just a domino effect. The neck will get longer, the lower lumbar will actually get usually pressure relief. But look at this. So this is from Percy Tomita. You are actually, and this is an adult, you're opening up, not an adult, because they're getting their baby teeth, so they're prior to 12. They're opening up. You're changing it. Which I should show the case here. But it's not just the width, they're getting AP. So you're pushing forward the alveolar process, which brings the teeth. That's why you get these facial changes. You're moving and creating volume inside the cavities, inside the maxilla, inside all these areas to create, you actually increase the vertical. Because the palate drops, so it goes from high vault to a shorter vault as the teeth come out. This is a 3D modeling that Dr. Singh at Biomodeling does, and they actually can put one on top of the other and measure out the actual volume changes of different points, landmarks. So this is So this is an adult. You can expand jaws by, it's not moving the teeth, you're moving the whole alveolar process. And when you expand the upper jaw, you can change the face because the teeth are connected to the maxilla, connected to the zygomatic, connected to the temporal, connected to the frontal. But you see how the neck changes also?
Yes.
The mandible comes down and forward. Exactly. Look at the mandible. It was steeper, and now it's down and forward. Look at the nose. Look at here how it had the bump. It's less of a bump. This is typical. This is consistently with all of us who do this. Now,
You changed your entire life.
It changes their lives. You know, my whole point is so people have better relationships, better attitude. You have better oxygen in your brain, you can think better. You can think better, you can act better. You can have more compassion for other people. So indirectly, I hope and wish to be helping community. Now, look, if you look at the second molars here, do you see how they're more pushed out? This is because it's the palatine bone. From the first molars on, it's all about our breathing apparatus. So this proves that this person does not breathe very well, despite their veneering cover-up. Can't cover this up fully. You know, veneers are very pretty, but the airway is more important. Okay, we know that. The pannus. And I see people a lot, and I see this pannus, I go, oh my word, they have sleep apnea. We need to really talk to them. They may look younger and better, but fact is they're getting more oxygen because their neck is longer and they're breathing better. But see the bump? The bump diminished.
Amazing.
The lips often get thicker. Okay, this is Dr. Harris. This one is unbelievable. Look at the open bite and the gummy smile. He's out of Canada. He actually closed the anterior open bite, but the facial changes is shocking. Isn't that shocking?
Again, it's life-changing. I mean, the cosmetic changes are amazing.
And you're not forcing the teeth into porcelain veneers. So, you know, you're getting aesthetics, but you're getting more the craniofacial aesthetics, but you're getting oxygen. You're opening up the chest. You're actually, a lot of them will actually get fuller. Okay. When you look at this, you know, I don't know about, it's really important. When you see those tonsils that are very large in the back, you're talking about adenoids that are very large. They may have them out, and sometimes tonsils come back despite having their adenoids supposedly taken because they can't grow back. The tongue. Here, when you have them open up their mouth, this is called melanpotty, and they have them to stick out their tongue, and if you can't see the back of their mouth, you have to follow up with a sleep study because there is a problem. Now, this is actually putting the instrument, one of the devices, and if you notice how the tongue just dropped down once you put it in there, because it actually creates a tongue reflex so the tongue drops down out of the way, because this tongue was protecting the airway. So if people ask me, what do you really do? I don't tell them I'm a dentist. Very often what I do is I said I utilize the teeth in order to decompress the upper vertebra. So I actually can change the C1, C2. And if you have any numbing in your arms and tingling, we can utilize the teeth in order to open up the vertebra. Now, what orthotic doesn't matter depending what they want, because it could be a decompressing device, it could be an expanding device, it could be a complete osseous remodeling, depending on the patient. But you're indirectly opening up the vertebra, which is really, really important that it's sustained in the right space. Too many people get surgery for herniation when they should be changing as their bite. A lot of this is formed when we're only 4 weeks old. So what our mothers do, what our grandmothers do is very important, because grandma has the little girl, that the little girl then has the egg, so that you have 3 generations in one grandma. What grandma does is very important. We have all kinds of theories of what's happening. Prior to myself being able to osseous remodel, I would look at this and just say, oh my God, I'm so heartbroken, because is it the genetics? Is it, they call it non-race mixing? I don't think so. If anything, a lot of interchange of the gene makes it a stronger gene. Thumb sucking, the question would be, why are they thumb sucking? It could be the pituitary, it could be a glandular issue. The food is getting too soft, I agree. I was in a functional forum the other day, and there's all these physicians, nutritionists, and what do they start talking about? Drinking their lunch and breakfast. And that they can, and I, of course, being the dentist, raised my hand and said, excuse me. I know I'm a dentist. I know there's a TMJ. I know there's teeth. I said, but I'm sorry, you're forgetting everything about proprioception. You're forgetting about the teeth stimulating the brain. You need to bite. You need to chew your food. Oh, and they got very defensive. I said, I'm sorry, you just told all these people, drink your breakfast and drink your lunch. Okay, well, you should chew. You should chew your liquids. And I was like, that's ridiculous. You have to chew. Our society's not chewing, and this is what's happening to us. That's where our digestion are going. So anyway, that's a side thing, because it's very important that we teach people to chew. So I have everybody chewing. So the kids tell me, go, you want me to chew gum? I said, yep, it is my prescription. I'm writing your prescription twice a day, 20 minutes. You have to figure it out, because we need to develop your muscles of your face, your airway, and I want you now to join either Taekwondo, I don't care what you do, figure skating, because you need to use your muscles in your body. That we were made to use our muscles. I'm not saying join a gym, a sport, a dance. You have to use your muscles. So anyway, facial bones. So what's happening is we are becoming very underdeveloped here and here. We are not chewing our food. Our food is destroying. It started 10,000 years ago with the industrialization. And that is a big deal because it's changing us dramatically. South America is beginning, and I'm South American, and that's why I say that, Colombian. I have a better jaw than most people, but my sister has a better jaw than mine. Why? She sings. I decided her singing actually creates some kind of resonance. Her bones are better than mine. It's her singing. And my nieces are singers, and they have these gorgeous jaws. And of course, I developed their jaws further than what they were born with. But this is what we used to be as hunters. This is what we're becoming. We're going back retrognathic, and our bones are getting smaller. We need to chew. Let me take an intermission on this one because I want to show something. This is a little girl. This was her jaw. This is how you really see her jaw.
Wow.
Yeah. This is the 10-year-old. Okay. And it really is this much. So
That's
this little
amazing.
jaw. Yeah.
Wow, wow, wow.
And we did it all with removable. At this moment, this is what we got from here to here. It took about 2.5 years. This is not overnight. I'm trying to be fair. Her lower jaw. And the only reason I ended up putting the braces on, you're going to laugh. She wants to show everybody that she's had work done.
How cute is that?
Yeah, she insisted, and can she have purple? And so this is when I put the braces on her, so that the overbite is gone. Now, I've had a few orthodontists, because I teach, and I teach both general dentists and orthodontists. It's interesting to see when they see a case like this, what they want to do is they want to hold back the upper jaw. The thing is, if you hold back the upper jaw, what happens, you're going to cause TMJ. And if you hold the upper jaw, you never focus on bringing down this one down and forward enough. So what happens, I'm now treating again some nicely standard dentistry orthodontists treated their best that they could, but the thing is, they're still retrognathic. Their neck is still forward posture because I don't hold back the jaw, I develop it. So I develop the width, because I want at least 38 to 40 millimeters across. And what's interesting is when you have the width, the rest of the jaw does the right thing because they're breathing. Now she was, of course, she was a sleep apneic. She was a sleep apneic. How can you not be a sleep apneic? So we brought the jaw down and forward, and the upper jaw, just from the correct breathing, myofunctional therapy, actually came down. And that's how we got, and her face is gorgeous. She now is one of the most popular girls in the school. The other day she had red, blue, blonde stripes in her hair. That's how popular she is. That's a big popular. Okay. But now it's interesting because she's become very tooth conscious. So we put the braces on, again, about 6 to 8 months. I don't put them for a long time. I just level them off and then release them for the natural breathing and the natural posture, because what they need to do is to develop their tongue in the right position, the tongue flat up, so they have to, do their horse, do their chewing gum, because that's what's going to hold the case, not a retainer. You want to be able to sustain natural. So my practice is a wellness practice. So it does craniofacial, but it really looks at TMJ. TMJ is supposed to become a specialty. There's all these specialty boards doing this. And I want to stay in general practice because who would diagnose these early enough? Everybody, a TMD or a sleep case when they're getting very sick. So a lot of these chronic fatigue, what's the other one? Fibromyalgia. Guess what their real premise is?
What?
Sleep apnea.
So you and I have been doing this for 3 decades. What do you think made sleep apnea just come to the forefront? I noticed the #1 New York Times best-selling book right now is by Arianna Huffington.
Yes.
Have you seen that book?
Yes, I was at her launching.
What do you think of her in particular and her book?
Oh, it's great. She did something well because you have to be conscious about sleeping. You have to be conscious of ceremony. I have a forthcoming book coming out, and it's really funny how we have very similar philosophy, but essentially it's a ceremony to go to sleep. You have to respect going to sleep, and including taking all the electronics away. Our children are working too much with electronics, and they get mad at me because I take it away and I look at them, I go in front of their face and I look at them, I go, I'm talking to you. But that's the kids in my practice. They need to put it away. They need to also respect food. So there's a ceremony of really not eating at least 2 to 3 hours before going to sleep, putting the electronics away, dimming the room, respecting 10 o'clock to be the time to go to sleep. Why? Because you get the best melatonin and serotonin. So you get your natural antidepressant when you sleep at 10 o'clock because the flush of those hormones at 2 o'clock in the morning. Then you sleep 6 to 8 to 9 hours. We're meant to sleep 8 hours. We really are. So that what she talks about is very good. The kind of pillow is important to some, not everybody. The mattress itself, you have to keep all the electronics away. Polyesters are not the best thing to sleep in. You have to go more natural cottons, more flannels. Those things are important. So what she's doing, and then also the teenagers. She's now going to the colleges. She's being sponsored by the colleges, and to learn how to go to bed early. Not to be the teenager, though I'm a teenager, I sleep. If anything, they need to sleep more. Changing the entry into the schools at 9 o'clock actually is a very good hour because they need their hormones to be balanced. We're going to have better teenagers, better drivers. All those accidents because they were sleep deprived. It was all sleep apnea. It's the saddest thing in the world. It's very, very, very sad. Very important. So I started TMD 18 years ago. When you start doing TMD, you start realizing there's another factor that we're not talking about, how these people are exhausted. You first take the pain away, and if there's sleep apnea, with the TMD treatment, they will lower their sleep apnea by 50%, but you still have the residual of sleep apnea. Whether you advance your jaw with a sleep appliance or you actually osseous remodel, that's going to be your question and their decision. Or they can lose weight, but 10 pounds only does 2 to 3 points of index points. So it's a lot of losing weight. There's even now things for a reactive protein to decrease the reactive protein that then decreases the leptin. The leptin is a hormone that decreases as your fat increases. So there's a problem with the chemistry. Periodontal disease contributes to the same secondary messengers that actually increases sleep apnea. The cytokines, interleukin 1s, interleukin 10, tumor necrosis factor, all the same. That's from my laser world, where I used to, where I used to teach laser, and the same inflammatory products of periodontal disease is the same thing that actually contributes to the sleepiness of sleep apnea.
You know, so many of these people listen to this podcast on iTunes. I wonder how I could get you to go back and create an online CE course for Dentaltown. We have 215,000 dentists on Dentaltown, and now we came out with an app which also has online CE. 50,000 dentists have the app, but we put up 350 courses on Dentaltown, and they've been viewed 600,000 times. And your presentation was outstanding. But if you're listening to this on iTunes, you could go back and see it on YouTube or Dentaltown. But I was thinking an online CE course from you would be amazing.
You got it.
I also, and I'm Howard at Dentaltown, but the man who does online CE is Dr. Howard Goldstein in Bethlehem, Pennsylvania. So his email is Hogo, Hogo at Dentaltown. But I want to ask you some,
one thing. This one part of my practice, the craniofacial, so 30% to 50% does that. The whole point to all this is wellness. How are you going to create a community that can do what they're supposed to do? How is that community do the mission that they were meant to be? And it could be raising their son and daughter really well. It could be serving some committees that would serve other communities. Because if you don't have the energy and the stamina to do all these things, this is where we dentists actually have a value, all of us dentists, because there are other things like the gene, the apolipoD4 gene. Okay, there are genes that cannot afford metal fillings in their mouth. They are vulnerable. It's not that the material is going to hurt everybody, it's the gene of that person. So there's a different way of viewing things. So I do wellness, so I do zirconium implants, I do infections. It's really funny because I don't let the practice get high volume so that I can really take care of people. So they have their little networks, whether it's a sleep doctor, an ENT, it's also the chiropractor, it's also the energy worker, it's also the osteopath. Because if, like I have a patient, she had trauma, I'm making sure she sees an osteopath that's going to cradle and support what we're doing. So it's really a wellness practice. And what I've noticed is all the academias are going into wellness. Have you noticed that?
You know, over the last 30 years, it seemed like when I got out of school in the 80s, dentistry was more mechanical, and all occlusion was LD Pankey, Dawson, Coy, Spear, more mechanical, and dentistry was focused in the mouth. Now you see it going more oral systemic, and they're linking the whole body together, and it's kind of a new awakening in dentistry that the mouth is connected to the entire body, the breathing, all these kinds of things. What percent of dentists do you think are trained in myofunctional or even believe it?
I have to giggle on that one because I'm constantly sending dentists for myofunctional therapy. But the thing is, the dentist should train, but they're not necessarily the ones should know. They should have the knowledge. They should own the knowledge and understand why myofunctional therapy is so important. Why sticking their tongue out, going sideways, without moving the jaw is so important because I'm really exercising on my airway. It looks silly. In every lecture, whether it's dentistry or whether it's MDs that I'm teaching or chiropractors, I stick my tongue out at them and I move my tongue and I go, watch carefully. And they're like, oh my God. I said, this is legal. I am teaching you myofunctional therapy to learn the value of it, to learn the value even the way it lifts the face, but then have someone in the office do it for them. Because you have to have some, either whether it's a hygienist or whether you subcontract a myofunctional therapist, have it done in the office. It makes all TMD sleep. Dentistry better because it's the soft tissue that governs the body. Our teeth, our bones don't really govern the body. It's the soft tissue.
Do you get a lot of resistance over the years trying to teach this to dentists, trying to get them to think about this?
No.
You don't?
No.
Is that because of your good looks and charm, or
Smile.
it's a smile? Also,
No,
you
so
were
what I do is I bring it in from the science. I speak about the gene, and I speak from the gene where they're going to get these diseases. Wouldn't you want to get them a network that may prevent them from getting that sick? Because that gene, if you look at it another way, that gene will make the Parkinson, that gene will make the sleep apnea, that gene will make an Alzheimer's. So I always ask, wouldn't you like to be the possibility that it could be at least partially reversed? Partially not as bad? And from that perspective is a good perspective.
when you were chairperson of the international chair of the American Academy of Cosmetic Dentistry, did you see a variance of myofunctional around the planet, or are some countries more into it, others less?
There are some countries that actually are much more into it. I'm shocked. First of all, Brazil, they actually put it into action first in a smaller town, and then it became a federal action. They look for tongue tied at when the baby is born, when the fetus comes out. It is part of the law to look for a tongue tied, because the tongue tied affects so many things. But if it's going to affect breastfeeding, it's going to affect even the relationship with the mother. That is the law. Brazil.
And at what age would they treat that? What would they do? Would they laser that? Or
I have my mommies actually going on their way home, drop off. And the best laser, by the way, and I have lasers and a half. I've been in lasers 25 years. But the one that now, today, is doing really well, the least amount of pain, the least amount of adhesions really is the CO2. The more that's easier to economically buy is the light scalpel. It's the CO2, and for little babies, it's almost like using it's almost like it's a lightsaber. It's just light.
Where is that made, and how much does it cost?
It's about 30,000. It's the original Luxar. Do you remember the company Luxar?
I do.
Original? Okay, so they've upgraded everything, and that's a very reasonable number for a laser.
LUXOR?
Yeah. I have to get you what the name is now, but it's the original Luxar.
What country was that made in? You remember?
I don't remember, because I remembered I went to buy my original was going to be a Luxar, and I ended up buying the Excel Quantronic and ND Yag with the Homium.
Huh. You are amazing. That was the fastest hour I've ever done on a podcast. I cannot believe it's been 1 hour. But Martha, this course would be is so visual. Would you get with Howard Goldstein and create this online too?
No problem.
That would be amazing.
But I would love to do more because I think people should get more into the zirconium implants. I think that they should expand more bone. Some zirconium. People really need teeth. They need to stimulate their brain.
And what's the name of the zirconium implant?
The one I prefer is the Z implant.
The Z?
Z implant system. ZI. It's from Switzerland.
Z implant system from Switzerland.
Zebra. Z like zebra. Now you can actually interview the president, because he's a hands-on dentist who invented it.
What's his name?
I forget the second two. Write that down.
Well, email me, howard@dentaltown.com, and CC him. And
be wonderful to take really. And in our practice, we're doing it 5 years. I have a surgeon who's been doing them also 5 years. I'm doing them 3 years, and they're just outstanding because the gingiva loves the zirconium. So instead of moving away from the zirconium, it hugs the gingiva.
You know, when Gordon Christian lectures on implants and says that a lot of peri-implantitis is an allergic reaction to the metal, I'd say lots of people snicker and think that's crazy. But you believe Gordon Christian, correct?
I am delighted to hear some possibility, because as part of the hypotheses, we often look at some of our patients because their tissues is just too inflamed. But you know what? Whether it's a tooth or an implant, it's just simply periodontal disease. And what I've done is I've taken DNA samples from the implants that are failing. The metal ones, I've taken DNA samples from the perio. There are so many critters. There
Right.
is stuff in some people, and it varies. It's not the same. So I originally was involved with Boyd Haley. Do you remember Boyd Haley?
I do.
Okay, so I used to do his $800 very expensive DNA testing for the root canals, because some of them might have been toxic on some of these people, so we would remove them, but I would do the DNA testing. Now there's a reasonable testing DNA. It's only $250. But now we use that as to say whether there's a problem with the bacteria. And some of those implants that fail have a lot of critters. It's shocking, the critters. So the question would be is what are we going to do with all those critters? How are we going to treat them?
And how are you treating them?
That's when I go to my practitioners and say, we are forming a little a team for this person. What do we need to do? And some of my practitioners actually involve themselves in not just antibiotics, but detoxing the system, cleaning out the gut, and the microbiome.
Well, Martha, thank you so much for spending an hour with me today. I can't wait to see your online course on Dentaltown. And the next time I'm in New York City, we have to get a cup of coffee.
Oh, I'd love to. That'd be wonderful.
Okay, and thanks to Ryan. Thanks for doing this, Ryan.
Thank you. Thank you, Al. Bye.